Hi everybody, Megan May here. I'm just making you an extra video to finish up the last two slides from class. So if you could pause this guy for a second and pull up the clinical parasitology PowerPoint from class last week. I'm going to talk about slides 11 and 12. So pull those up on another window or another device or whatever so we can take a peek at them while I'm talking to you and go through this jazz and pretend like we had this in class. So I will tell you that some of this material does appear on the progress test, so you're definitely going to want to pay attention to this. Alright, so once again what we're looking at here is, if I can get my stylus working, it's not working. Will my finger work? Yes, it does, cool. So forgive any handwriting disasters because you're dealing with me writing with my finger. We're going to be looking at the urogenital parasite and some delusional parasitosis. Alright, so we have one urogenital parasite that I want to talk to you about, and this is Trichomonas vaginalis. This is an image of it right here on a wet mount. This is a protozoal parasite, and it serves as the exception that I kept alluding to when we talked about how all parasites, all protozoa have a cis form and a troph form and have two life stages. And I said with one exception or minimal exceptions, this guy right here is the exception. Trichomonas only exists as a trophozoite, so people don't shed Trichomonas cis, and this is only transmitted directly by very close contact. So, one thing that people don't think much about, but is true, who is the most common STI, it stands for sexually transmitted infection, it's actually Trichomonas. But because many people carry it asymptomatically, or you only get symptoms when you have co-infections with other bacterial agents, it's not typically thought of that way, but it is absolutely the most common sexually transmitted organism. So, two fun facts about it we've learned so far: most common, and this only exists as a troph form. So if you have a trich infected patient and you take a vaginal swab from them, you're not going to see a mixture of cysts and trophs. People don't shed cysts, again, as mentioned. You'll only see these guys right here. Okay. The clinical state associated with trichomoniasis is non-bacterial vaginitis. So this is where you have inflammation of the vaginal cavity, and the patients who present with this obviously are women, but they'll present with vulvovaginal irritation and pain. So there's a lot of redness, a lot of itching, a lot of descriptions of just sort of this burning pain that doesn't really go away. In addition, there's often a vaginal discharge. It's either yellow or green, and instead of being kind of thin, clear mucus, it'll be much thicker and obviously again have this coloration to it. It's also described as malodorous, so it's not a benign discharge. It does not smell good. It's very clear to the woman suffering from trichomoniasis that something's rather wrong. Men who are infected with it, which again you do not typically see, this is a very unusual clinical presentation, but it does sometimes happen. Trichomonas can be found in men, causing a urethritis with an associated urethral discharge that again is bad smelling and miscolored. Usually doesn't get quite to green level in men, but it is definitely can be opaque and yellow. So I want to underscore, though, this is not an STI that you find equally distributed in both sexes. This is primarily a disease you see in women. And the men that you see presenting with trichomoniasis usually are multi-STI patients or have some underlying condition. So that is our one urogenital sexually transmitted infection. The last thing that we're going to talk about for parasitology of the skin is a phenomenon called delusional parasitosis. So Dr. Smith talks a bit about this in Year 2's curriculum during psych, but I wanted to mention it here because it's a very rare but rather important rule out for ectoparasites. Delusional parasitosis is sometimes called Ekbom syndrome, but basically what it describes is this itching and crawling sensation of having bugs or worms under your skin. That being said, if we make sure that a patient does not in fact have bugs or worms under their skin, we have to think about what is actually causing this. A lot of times this is drug-induced. So if you are dealing with a population that has a heavy burden of drug use, particularly methamphetamines, this is something that you might want to think about. If your patient thinks there's bugs under their skin, you might want to run a tox screen on them. You can have some presentations of Ekbom syndrome from extreme hormonal changes, but that's not nearly as common. Most commonly, this is a drug-induced phenomenon. The last thing, before I move on, there is a rare situation, I mentioned it very briefly in class, where you can have delusional parasitosis following actual ectoparasitosis, particularly in patients who've had botflies or screwworms or something just really horrific like that. The idea that, and the fear that this might be coming back and starting again is a very real thing. And so sometimes these are patients that, we want to take their Ekbom syndrome very seriously and reassure them that it is not a reoccurrence of their previous ectoparasitosis, but that this is a delusional situation, and this is something that you may consider medicating for, but from a psychiatric perspective rather than an antiparasitic perspective. Okay. The last thing I want to bring up is a condition called morgellons. So this is one of those controversial conditions that that there's a very real patient population that talks about this and exists as a community online. And the issue with this is that we can't seem to find an underlying infectious cause for morgellons. So what this syndrome actually consists of is patients who have these very sudden onset itchy lesions and this sensation again of something crawling under their skin. And what ends up happening is that, and what kind of defines this as morgellons, is the emission of fibers from these lesions. So the problem here is that with peer-reviewed studies and extensive studies of these patients, we can't really find a single underlying commonality, and most of the fibers that come out when they're examined and tested, they are usually textile fibers. So in other words, the fibers are real, but they're from cloth that gets stuck in the lesion. And the problem here is that you have a patient population that truly is suffering. There's no question about that. But how best to treat them is really the question. And if we look at morgellons as a delusional parasitosis, and that's something that we don't want to use derogatively, because these patients really, again, are suffering. There have been a couple of studies that show treating them with a psychiatric medication actually improves symptoms. So that argues in favor of this being a delusional parasitosis. And coupling that with the underlying lack of commonality, that's more or less the consensus that people are coming to. And that doesn't, again, at all minimize the suffering of these patients, but it does call into question the best way to actually treat them. At this point, there is not good evidence to suggest that this is an infectious process. There have been some links made to Lyme disease or non-Bergdorferi borreliosis. Those words will make sense to you after week 16. But there's, again, the link to this between those two conditions doesn't seem to be validated by epidemiology. And if this were a condition that could be treated with doxycycline by getting rid of undiagnosed Lyme disease, that would be a wonderful thing to celebrate, but it doesn't seem to be the case, unfortunately. So I've also added in a link to an NBC News clip that's into the email where I'm sending out this link to this video. I will also put it in the comments for anybody random who's watching online. But it's unfortunate. I wish it could be treated with antibiotics, but it doesn't seem to be the case. Perhaps further studies will demonstrate this conclusion to be incorrect in the future, and I think that would be wonderful if that were the case. But right now, it does seem to be a condition that we would medicate psychiatrically and symptomologically rather than anti-infectiously. So, all that being said, that's all I have for this video. I hope you found it informative. Feel free to shoot me an email with any questions, and I will see you guys next time.